Okay, now we are moving on to issue number, or to Department of Managed Healthcare.
All right, good afternoon. Can you hear me okay?
We can.
Yes, great. So I'm Mary Watanabe. I'm the Director of the Department of Managed Healthcare. And I have with me today our Chief Deputy Director, Dan Southard, as well. So I'll start with just a quick overview of our proposal, the Annual Healthcare Service Plan Health Equity and Quality Reviews. The COVID-19 pandemic has exposed long-standing health inequities seen among people of color. The pandemic has also highlighted systemic racism and discrimination that has created social, economic, and health inequities contributing to disproportionately higher infection and mortality rates. The administration is committed to addressing health inequities and is proposing statutory changes to authorize the DMHC to establish and enforce a priority set of health equity and quality measures, including setting annual health equity and quality benchmark standards and enforcing health plan compliance with these standards. The proposed statutory changes would apply to full service and behavioral health plans licensed by the DMHC, including health plans that contract with the Department of Healthcare Services to provide healthcare services to Medi-Cal beneficiaries. The proposed statutory changes add the following new requirements. The DMHC will convene a health equity and quality committee in the first half of 2022 to make recommendations to the DMHC on a priority set of standard health equity and quality measures and annual benchmarks. The quality committee members will include state departments, purchasers, consumer advocates, healthcare service plan representatives, provider representatives, and those with expertise in quality measurement and in health equity and disparities in the healthcare delivery system, and other entities as appropriate. The DMHC will contract with an external consultant with expertise in this subject area to assist the department in planning, organizing, and facilitating the committee meetings. Based on the committee's recommendations, the DMHC will establish a priority set of quality measures and health equity and quality benchmarks for all full service and behavioral health plans. The plans will annually submit a report containing data and information on the measures and annual benchmarks to the DMHC beginning in 2024 for measurement year 2023. The DMHC will have the authority to require corrective action plans and take enforcement action when health equity and quality benchmarks are not met. This includes monitoring corrective action plans and improvement efforts where needed and taking progressive enforcement action against non-compliant healthcare service plans as appropriate. The DMHC will produce an annual health equity and quality compliance report beginning in 2025. The DMHC will make changes to the health equity and quality measures and annual benchmarks until the requirements are codified in regulations. In addition, the plans and their subcontracted health plans will be required to obtain and maintain National Committee for Quality Assurance, or NCQA, accreditation by January 1st of 2026. Throughout the development and implementation of this proposal, the DMHC will collaborate with OSHPD, DHCS, Covered California, CalPERS, and the Department of Insurance in establishing the priority set of standard quality measures and benchmarks. The DHCS will coordinate with DMHC to conduct similar work for county organized health systems that are not required to obtain a NOC scheme license. The DMHC requests the following positions and expenditures authority from the Managed Care Fund to establish and enforce health equity and quality standards for all DMHC licensed full service and behavioral health plans on an annual basis. 2 positions in $952,000 in fiscal year 21-22, 2 positions in $351,000 in fiscal year 22-23, 15 positions and $3,584,000 in fiscal year 23-24, 19.5 positions and $4,441,000 in fiscal year 24-25, 19.5 positions and $4,402,000 in fiscal year 25-26, 24.5 positions and $6,315,000 in fiscal year 26-27, 24.5 positions and almost $6 million in fiscal year 27-28, and 24.5 positions and $5,434,000 in fiscal year 28-29 and annually thereafter. This request includes $500,000 in fiscal year 21-22 for consultant services to assist with planning, organizing, and facilitating the committee, and to advise the department on establishing a priority set of quality measures. This request also includes consultant funding of $539,000 in fiscal year 23-24 and annually thereafter for clinical consulting services to assist in interpreting data and determining trends related to reducing health disparities and improving the quality of care delivered. The Department of Healthcare Services requests positions and expenditure authority from the general fund and federal fund to coordinate with the DMHC on the establishment and enforcement of health equity and quality standards and to perform related data analysis. This includes 2 positions and $296,000 in fiscal year 21-22 and 2 positions and $278,000 in fiscal year 22-23 and annually thereafter. So I'll pause there and see if there's any questions. Otherwise, I can move on to question 2.
Dr. Pan, a lot of positions, but we're doing big things.
Well,
Long list.
Yeah, a long list, a lot of words.
All right, and so I just first of all, actually, I probably have more questions when you go through the rest of the remaining questions. But just first of all, thank you for doing this, and I am interested in thinking about how you're going about doing this. But I note that that's in the next 4 questions.
Right.
But I just want to say thank you.
Yeah, no problem. Would you like me to maybe just get through the questions and then
Yeah, I think that'd
keep
be
going?
great.
Okay.
I think that'd be
All right.
great.
So the second question is, how would DMHC approach ensuring the availability of relevant and diverse expertise on the Health Equity and Quality Committee? So as I mentioned, that we intend to include our sister agencies, the other state departments, purchasers, consumer advocates, health plan representatives, providers, and other entities with relevant experience. Our intent is to issue a solicitation for members and select members with expertise in quality measurement, but also in health equity that represent the diversity of the state, including racial, ethnic, cultural, gender, geographic, and other diversity of the state. We also, as I mentioned, plan to contract with an external consultant with expertise in this subject area to assist the department in planning, organizing, and facilitating the meetings. We're expecting that the external consultant may also have expertise and recommendations for who to solicit participation on that committee and can help us with making recommendations. All right, moving on to question 3. Please describe some examples of the types of equity and quality measures and benchmarks that could become new plan responsibilities as a result of this proposal. To reduce administrative burden on both the health plans and providers and to avoid duplication, the intent of this proposal is to select a priority set of measures, and we're talking probably somewhere around 10, 12, 15 max, that are currently collected and reported to other entities such as DHCS, Covered California, and CalPERS. We will look to the committee to make recommendations, but this is likely will include a subset of quality measures, as I said, collected by health plans, including healthcare effectiveness data and information set measures or HEDIS measures, and consumer satisfaction surveys such as the Consumer Assessment of Healthcare Providers and Systems, or the CAP survey. The measures may also include those conditions that disproportionately impact communities of color or other vulnerable populations, and could include a mix of child and adult measures. Some examples of potential measures include diabetes control, control of high blood pressure, cervical cancer screening, colorectal cancer screening, asthma, prenatal and postpartum care, opioid use, immunizations, and depression screening. Some examples of consumer satisfaction survey question include those related to consumer experiences obtaining necessary and timely care, access to culturally and linguistically appropriate care, health plan customer service, and the ability to receive specialty behavioral health care services. The full service and behavioral health plans will make applicable modifications to their quality assurance program policies and procedures and annually collect and submit a report containing data and information on the priority set of measures and benchmarks to the DMHC beginning in 2024 for measurement year 2023. So I'll move on to question 4. Please describe some examples of the actions the department would expect of health plans as they seek to comply with the equity and quality measures and benchmarks. So if healthcare service plans do not demonstrate compliance with the measures and benchmarks, the DMHC may require the healthcare service plan to implement corrective action plans to achieve and demonstrate compliance with the health equity and quality standard measures and benchmarks. Additional expectations may include the health plan identifying root causes of failure to meet the benchmark standards conducting outreach to their contracted providers, assessing the effectiveness of payment incentives or other interventions, and making changes as necessary. We also can require provider plans to submit more frequent reporting as part of our monitoring oversight process. And then the final question, number 5 here, is after the required promulgation of regulations in 2027, does DMHC expect to have to promulgate new regulations when equity and quality measures and benchmarks are updated periodically? So this is a tough one. I will say in order for the department to take enforcement action and avoid potential legal challenges, we believe that we will need to codify the measures and benchmarks and regulations. We will need to amend the regulations if we make changes to those benchmarks or measures. We intend to reevaluate and make changes to the equity and quality measures and benchmarks as necessary. We're really going into this with an acknowledgement that there is a lot that will change as we start to collect this data, both in the measures and the data that's available to assess the quality and health equity. It'll be important for us to continually reevaluate and work with our stakeholders to make sure that we're making appropriate changes to the measures and benchmarks as both technology and the delivery system evolves, but we'll need to codify that and amend the regulations. So that, I think, concludes the questions that formal questions, but I'm happy to now take any questions from you.
Thank you very much. Anything from the Department of Finance?
Thank you. No comment.
Okay. LAO?
Madam Chair and to the committee, this is Ben Johnson with the Legislative Analyst's Office. Just want to briefly note that we support the goals that underlie this BCP and specifically find that measuring and reporting and holding plans responsible for meeting for their performance against quality and equity standards can drive improvements in the healthcare system. We recognize that carrying out these new activities would reflect a significant undertaking for DMHC and don't have specific concerns with the resource request or the associated proposed statutory changes, and just recommend continued legislative oversight of the administration's efforts as they develop the performance standards and as they develop the processes for monitoring, reporting, and enforcing those standards. Thank you.
Thank you very much. And I guess my first questions would be around, well, again, acknowledging and thanking you for your work with this, but also then, again, just the idea of equity regionally around the state, just if we can keep that in the forefront of our mind. And what is your plan then for maintaining, I mean, we're going to be collecting a lot of data, setting a lot of benchmarks. Are we sure that we're going to, I guess, I want to keep saying this, how do we avoid the ADD debacle when we're looking at IT and then data collection? You can start there, please.
Mm-hmm. Yeah, no, and I will say that, collecting HEDIS data is something that, the plans are already reporting, again, with this idea that we're not, creating a new set of measures. This is really built around identifying measures that are already being collected and reported to purchasers and other state entities. And so this is not, in terms of like submitting the data, this is not huge databases. This is data that can be just submitted and aggregated by the department fairly simply. So again, already data that's being collected and reported, but we'll make sure that we have the appropriate oversight and protections in place, similar to how we do with the other data that we collect.
And can you talk a little bit about one of as one of my other hats as the vice chair of the LGBT caucus, one of the things that we talk about a lot is the collection or the lack of collection of SOGI data, but the lack of reporting that or documenting that somewhere. Are we going to make sure that we have those equity factors mixed in as well or included as well?
Yeah, no, and that's actually a priority for us as well. I will say one of the challenges we have overall in data collection is we don't have complete and robust data on both race, ethnicity, obviously SOGI data as well. And there's a number of ways that we can look at that. We can look at geography and other proxies. It's an area that we really will be looking to both our sister agencies, but also the committee to advise us on how do we capture that data? How do we make sure that we're not missing out on certain communities? This is another area that I think we are cautiously optimistic that as time goes by, the availability of that data will improve And this is where our ability to be nimble and move and make changes to the measures and the benchmarks will be important.
Okay. And while we're going to be using this data to increase equity and use it for providers, what is the ideas about the relationship back with the legislature as far as reporting this data so we can be aware of where the gaps are of which providers are being able to meet the outcomes? What's your idea about coming back to the legislature for updates and reports?
Sure. No, and we're always happy to provide updates on the work that we do. I think the key piece here around transparency will be the annual report that we will have on our website. So our goal is to have an annual report starting in 2025 that'll be available on our website that will show how the plans are doing in terms of performance and meeting those benchmarks.
Okay, thank you. Dr. Pan?
Thank you so very much for your presentation. And certainly I understand, and I share your desire not to increase administrative burdens on the plans who are already reporting a lot of data to the department and to our state government. However, I think if we're dealing with equity, we need to recognize that the systems that we have in place now did come from well, let's put it this way, systemic racism is something that's built into our systems. So I think we do need to look carefully at our existing data systems, data collection, and look at what are the things we're not collecting that we perhaps should be. So I appreciate that you're looking, you're trying to just stick to things you already get. But I just want to put that pin on there, not to say that let's go and create a whole bunch of new measures. But I do think that's, so, but the one place I think we really do need to think very carefully about and work with the plans, but be sure we get really good and accurate data, is around the beneficiaries themselves, because without that, all the rest of it you can't really interpret. So, for example, do we have a system in place to confidentially and accurately at least try to collect data on, sexual orientation and gender identity, right? Because basically, if there isn't a mechanism to do that, there's no way you're going to be able to look at that. And then I think for the API community, having disaggregated data. So, I mentioned that the API community represents people who come from the biggest continent in the world and the biggest ocean in the world. And there's a lot of diversity within that community. And so if you don't get the disaggregated data, you're going to miss a lot of things there. So I'm not sure the current systems are adequate enough, and that if we're really trying to achieve equity, we need to demand that those systems are better in terms of that baseline data, because otherwise you can have all the HEDIS and all this other stuff, and you're not going to be able to parse out. If you don't have the LGBTQ data, you don't have the disaggregated API data. Simply say like Asians are doing fine and et cetera. But it could be that actually, the Pacific Islanders aren't doing so well. In fact, we see this with COVID, right? Pacific Islanders actually have the highest death rate of any group. But if we just folded them in as API, that would have been lost. So I think that's really important that in an equity framework that not to say that, well, what we have is good enough. We're going to have to do better in collecting at least some of the data. The other thing that I also want to mention is that in addition to, of course, to the data you collect, is also how you analyze the existing data. So let me just pose this question. Let me just, before I pose this question, I also want to get back to, certainly for the API community, but for other communities of color, access to interpreters. All right, and when I say interpreters, not just translation, all right, not just a phone person. So are we going to be collecting data on access to interpreters, medical interpreters, and the, for example, percentage of times that happen, and so forth. So it's not just like a call a phone thing where you have someone who literally translates and so you don't get the cultural context, et cetera. Are we going to be collecting that information as part of this equity effort?
Yeah, no, just on the collecting of race, ethnicity, and SOGI data, having worked on this throughout my career, there's always this trying to find this balance from trying to capture the data to do the appropriate measurement without creating a barrier to enrollment. And it is something that I think we will continue to work on, and particularly working with purchasers who are involved in the enrollment process as well. In terms of access to translator services, that is probably
I'm going to say interpreter services. There's actually a difference.
So translation?
Translation is different than interpreting. Translation can just be literal translation. I'll tell you, as someone who's a healthcare provider, a literal translation, while more helpful than nothing, doesn't include the cultural context of the interaction. And so it's not as useful. That's why I use medical interpreters, not just translators.
Sure. No, and I think the opportunity there is probably through some sort of consumer satisfaction survey to really understand the member experience.
Well, for example, I assume they code for this, because usually it's often an expense. So is there a way we can collect it aside from just asking the patients, that we actually have administrative data around level of payment, how frequent, how many appointments they pay for? That's a level of access.
I would certainly take that back, and something that we can have a discussion with our committee about.
Okay, so certainly, yeah, I appreciate catching it on the consumer end, and I always recommend, I think in our conversations in the past, do you survey the consumers as well? In this case, it's a little reverse, because you have the consumer information perhaps from CAHPS, and again, that's from the sample. Going back the other way, I think it's useful to get comparisons to what they're actually paying for and how often they're paying for, et cetera. And then that, of course, is tied to not only beneficiary, but also perhaps also some geographic data, right? So they're living in an area that has high density, et cetera. If one plan isn't paying for very much and the other one is, it might be telling you something. Okay, so again, certainly for the API community, this is going to be really, really important. But I imagine that there are some other communities as well. And then the other piece of data I think you need to be looking at from an analytical standpoint. So, you do get data on which providers they contract and, where they are and so forth. So you get that information. But are we going to do analyses and also something the beneficiaries and where they're located, so geographic, et cetera. But are we going to look at the distribution of the providers, for example,